പഴയ കാഴ്ചപ്പാട്. അപ്പൊ ഞാനും ഓക്കെയാണ്. പക്ഷെ കാഴ്ചപ്പാട് ഞാൻ ടീം ഞാൻ ചെയ്യുന്നില്ല. കാരണം എല്ലാം ഒരേ ലേബിലുണ്ടാ. ഇങ്ങനെ പറയുമോ ആ കൈലോടിലോട് ഫസ്റ്റൊക്കെ മിതാവ് ഓരോ വോയിസ് ആക്കുന്നതല്ലേ കുറ്റനാണ്. നമ്മൾ പ്രീവിയസ് കുട്ടിയൊക്കെ കുറ്റവർത്താനൊക്കെ പറയും. അതൊന്നും തീരില്ല. എന്നാലും അല്ലാണ്ട് ഇടയ്ക്ക് സമയം നമ്മൾ നൈറ്റൊക്കെ ആവുമ്പോൾ ചിലപ്പോൾ വർത്താനം എല്ലാവരും കൂടി ഒരുമിച്ചിരുന്ന് വർത്താനം പറയും, കളിക്കുകയും
Miss Fatima Farzana. Fatima Farzana. அப்புறமே யார்கிட்ட இருந்து சவுண்ட் வருது?
From party.
Welcome participants, welcome dear students, and welcome our beloved resource person. And we are very happy to have this session with you. And indeed, it's God's blessings. We are having such a great opportunity to hear. So let us start this virtual meet.
Thank you for this opportunity. Good afternoon, everyone. Can you hear me? Is the audio stream?
Yes, sir. You're audible. We can hear you. Yeah. Thank you, sir.
No, please don't.
The first step towards getting somewhere is to decide you're not going to stay where you are. Respected dignitaries, scholars, and professors, and my dear student teachers, a very good afternoon to one and all. Myself, Srimati, student teacher, feel privileged to welcome you on behalf of the organizing committee of today's international webinar, St.Ignatius College of Education, Parliament Hotel. A hearty welcome to you all the afternoon session of today's international webinar, Psychotherapy and Overview. Small cheer and great welcome makes a merry heart. Now let us have the pleasure of listening to the opening remarks. May I request Ms. A. Priscilla to deliver the welcome address.
Welcome to the present moment here. Now, the only moment there ever is now. A very good afternoon to one and all gathered here. I'm glad to deliver the welcome address for the second part of today's session. It gives me immense pleasure to welcome our charming secretary, Reverend Sister A. Gemma, who enlightens us to come out of our shell. It's my delight to welcome our vibrant principal, Reverend Sister Dr. L. Vasanthi Medona, who always encourages us in all our activities. It's my great honor to welcome our resource person, Dr. Anto P. Rajkumar, Clinical Associate Professor and Academic Training Program, Director of Psychiatry, Institute of Mental Health, University of Nottingham, UK. Dr. Anto P. Rajkumar is a very elegant person working towards connecting young minds to strive towards success and achievement. We are grateful to you, sir, for accepting our invitation for today's event. We welcome you, sir. Next, I would like to extend my hearty welcome to Reverend Sister Dr. A. Nirmala Devi, former principal of our college. Dr. E.C. Punita, Dean and Associate Professor of English. Dr. M. Maria Saroja, Research Director and Associate Professor of Biological Science. Dr. N. Teresita Shanti, Controller of Examinations and Assistant Professor of Physical Science. Dr. A. Jayasudha, Vice Principal and Assistant Professor of History. Dr. J. Maria Prema, Assistant Professor of Education. Dr. S. Josephine, Directress of Physical Education. Dr. P. Jansi Rose, Librarian, who are the bearing columns of our institution. Next, I would like to welcome my dear student teachers to this wonderful session. Welcome the challenges. Look for the opportunities in every situation to learn and grow in wisdom. I welcome all the participants across the breadths and heights of our country. Once again, I welcome each and everyone on behalf of our ICM management. Thank you.
Can you hear me now?
Thank you, Priscilla, for your warm words of welcome. To be inspired is great, but to be an inspiration is an honor. With these elegant words, I would like to call upon Ms. Surya to introduce the chief guest.
Good afternoon to one and all present here. I am here to introduce the chief guest, Dr. Ando Praveen Rajkumar Rajmani. He is familiar as Ando Rajmani. Dr. Ando Rajmani has done his double PhD in biomedicine and also psychiatry. He is a medical practitioner with a specialist registration in old age psychiatry and also a member of the Royal College of Psychiatrists, United Kingdom. He is a member of the UK Society. He is a clinical associate professor in old age psychiatry and academic training program director for psychiatry, University of Nottingham in UK, and also has served as academic clinical lecturer in old age psychiatry, UK. He worked as associate professor of psychology, Christian Medical College, Vellore. He has excellent profile on research that has published 58 research papers, including 31 first or last other publications so far. He has written chapter of Dementia with the Lewy Bodies in the current edition of New Oxford Textbook of Psychiatry. He has 18 years of research experience and expertise on clinical psychiatry, molecular genetics, RNA biology, and relevant bioinformation. Also, he is experienced of designing and conducting basic science studies, translational research, qualitative studies, meta-analysis, clinical trials, as well as biomarker studies. To count his achievements in his field is countless. Sir has got first prize for the best research application by an academic clinical lecture in 7th Annual Integrated Academic Training Program competition in 2017. He received Professor Sarada Menon Gold Medal by the National Board of Examination, New Delhi in 2018. The Rose Chasco Prize awarded by the CMC Vellore, India, for scoring the highest mark in MD examination in 2007. I have presented only a part of his profile. Even a day is not enough to read out his excellence and achievements in the field of medicine. We feel honored for your humble presence besides your busy schedule. Heartily welcome, sir.
Thank you, Surya, for your warm introduction. Without taking much time, let us feed our mind eagerness by listening to the resource person. Now, I hand over the session to Dr. Anto P. Rajkumar, sir. Over to you, sir.
Thank you for the kind introduction. Good afternoon, everyone. I'm very glad to be with you this afternoon and talking about psychotherapy. Human mind is the most complex machinery we know in this universe. And any machinery can give troubles. And the psychotherapy is the way of troubleshooting human mind by talking and other means of psychological treatment. So you are learning psychology, and the psychology extends to applied psychology and clinical psychology. And in the clinical psychology, we deal with understanding problems with the mind and troubleshooting those problems. And psychotherapy is exactly that, troubleshooting the human mind's problems. Psychotherapy is a big topic with a lot of history, more than 100 years of history, and with a lot of schools of psychotherapy. And I'm trying to cover them in the next 45 to 50 minutes. That will be just a bird eye overview. So please feel free to interrupt me during my session. Our session is supposed to be interactive. So I don't want this to be a hierarchical one person, one directional talk. So please feel free to interrupt me. I don't see the chat box when I present. So you can unmute your mic, interrupt me, ask a question. We can stop and then continue. It will not do anything to the flow. So please feel free to interrupt me during my presentation. And the first slide, you may see my email address. So after the presentation, contact me with any questions. You can contact me at this question, anto.rajamani@nottingham.ac.uk. So first of all, why should we discuss this topic? Why do you need to discuss about psychotherapy? First of all, mental health difficulties are not uncommon. And the population you see, the adolescent and young youth population, it is estimated that at any given point of time, 1 in 10 have some sort of mental health difficulties, anxiety, depression, or another form of adjustment or coping difficulties. And if we extend that to the lifetime prevalence, it extends up to 1 in 4 to 1 in 6 people have mental health difficulty at some point of time in their life. So it is not uncommon. And usually teachers are often the first point of contact. You are the one who may recognize the problem early and provide first point of care. And if the care is effectively delivered at the level of teachers, they may not need further care. So 80 to 90% of people can be managed with your level of intervention, and they don't need further intervention and they continue with their life. And teachers provide holistic support. When a person with difficulty goes to a clinical setting to see a doctor or a clinical psychologist, they see their only one dimension, how they present to the clinic. But the teachers have the opportunity to see academic performance as well as in the other domains of their life. So you can understand the person better and provide a more holistic support and focusing more on their academic efficiency and overall career success. So you are in quite an advantageous position than anyone working in clinic. And part of your goals include to help students to reach their full potential in their life. And psychotherapy is a way to help students with difficulties to reach their full potential. And it's not just helping the students to reach the career development. Some element of psychotherapy, like learning to manage our own anxiety, learning to deal with our own loss and distressing events, that helps in our own career development. And so it is not just helping others, it also helps learning to help yourself. And psychotherapy helps improving own personal relationships. It deals a lot with interpersonal relationship and communication issues. So improving one personal relationship is also a way to improve your professional output. So to help us, to help your students, as well as to help yourself and your family. That's why we are discussing this topic today. So what are our main objective for this session? To learn basic principles of psychotherapy. Each school of psychotherapy has their own principles and ideology. But I'm not going into detail for the individual school ideology today. I'm going to present some overarching principles. They are common for all schools of psychotherapy. That's considered as a backbone, non-specific factors or common factors in psychotherapy. So I'm going to stress more about the basic principles of psychotherapy. And just to mention what are the various schools of psychotherapy that exist. And to more importantly, towards the end, I will tell you when to refer students to specialist care. I can tell you only a tip of the iceberg. You'll need referral. So the less than 10% need specialist support, and you need to know when to refer students, which students to refer for specialist care. And overall, to encourage you to recognize and to help common mental difficulties in teaching settings. So you might have come across the terms counseling more often than psychotherapy. So I will start further by stressing what's the difference between counseling and psychotherapy. So they exist in a spectrum. So the spectrum initially starts with advice. Someone comes to you with a problem. The human tendency and the easiest thing is to do is guide them what to do. That is advice. And that's one end of the spectrum. And the counseling comes next, and the psychotherapy is further down in the spectrum. So how counseling differs from advice, we'll start with that first, and then I will explain how psychotherapy differs from counseling. So counseling is any psychologically oriented talking intervention. It's a talking form of therapy. That is not merely advice. How it differs from advice? Because it's a non-judgmental, non-directive discussion. Advice, you set some values. You tell the person that you're not meeting these values, and you have to progress toward this idea. So that's not there in counseling. An ideal counselor should be non-judgmental, should not come with his or her preset values. And it's a non-directive discussion. So we don't give solutions. We will encourage the person to find their own solutions. So it's a non-judgmental, non-directive discussion. That's what makes counseling different from routine advice given to anyone. And counseling differs from advice because it comes from the background of a supportive, empathetic, therapeutic relationship. We listen good things from people only if we like them or trust them. So if there is no supportive therapeutic relationship, whatever the best piece of advice, that won't reach the person, and it will not be translated into their behavior. So counseling differs from advice by mainly being non-judgmental, being a non-directive discussion, and there's a relationship with this mutually supporting and understanding the person's problem. That is empathy. So that's how counseling differs from advice. How psychotherapy differs from counseling. Let's see that in this slide. So the psychotherapy is more goal-oriented. The counseling, we try to bring a person's inner strength out and facilitate them to find solutions for their own problem. And it's for the overall ability to manage a particular situation. But psychotherapy usually comes with defines a specific problem, like anxiety or a specific difficulty, and trying to correct that problem by techniques from different schools of psychotherapy. So being goal-oriented, setting specific goals, working towards that goal, and measuring the improvement by the standards of change in behavior in those goals. That's why how psychotherapy differs from counseling. And psychotherapy also. Yes.
Excuse me, sorry.
Yes.
We couldn't see this shared screen.
Do you see that now?
It's clear, but we couldn't see the screen. And also throughout, we can see the first, previously we are seeing just the first.
Okay. Thank you for telling that. I'm going back. Do you see the slide?
Thank you. Yes.
So first slide, I just want to highlight my email address for further questions. You may contact that. Thank you for interrupting and telling this. Please feel free to interrupt in between. So these are the points I mentioned for why should we discuss. Mental health difficulties are not uncommon, and to help students to reach their full potential, to facilitate your own career development and own personal relationships. And the objectives are basic principles of psychotherapy, various schools of psychotherapy, and to learn when to refer, and to encourage you to recognize and to help common mental health difficulties. So counseling is psychologically oriented intervention that is not merely advice. It's a non-judgmental, non-directive discussion in a supportive, empathetic background. And this is where we left. So psychotherapy is goal-oriented and with strict professional boundaries. So counseling, you may share your phone numbers to a person saying that you may call me if you're in trouble, but psychotherapy, you never do that. And if you do that, it's considered as a breach of professional boundaries. And counseling, you may see them out of hours, and psychotherapy comes with a specific professional boundaries. It is a time fixed, and you deliver the intervention in a more stricter professional role. So here the therapist deliberately establish a professional relationship with the client, and this clearly you identify a problem, and you aim to either remove the symptom. The symptom can be just an anxiety, a person avoiding a particular situation, or fearful of a particular situation, or unable to carry out a particular task, and trying to remove that symptom or modify the symptom, or trying to reduce its severity. So that's the goal of psychotherapy. And there are psychotherapies that the goal is more broader goals to promote overall positive personality development. So summarizing, counseling is one step above than advice because it is non-directive. It doesn't go with preset values, non-judgmental, and with the backbone of a supportive relationship. Psychotherapy built that further by clearly defining a problem and trying to change the problem in a goal-oriented approach in the background of a professional relationship. And some psychotherapists look for to promote positive personality development. So why is it needed? When is it needed in teaching settings? I think the three most common situations when students may require some sort of psychological intervention is the first one is stress and coping difficulties. So we need to understand stress. Stress is not purely external. Stress is an interaction between one's own resources, ability to cope with stress, and what's the external event is. So one externally even may not look stressful to the therapy provider, the teacher, but it may be quite stressful, backbreaking for the student who experiencing it because of the other situations in their life and their own coping difficulties. So stress and coping, either related to academic stress or other things going on in their life, that's the commonest situation when some sort of psychological intervention may be needed. And the relationship issues, relationship problems can be related to with their peers or with their family or relationship within the school setting. And loss and grief issues. This loss can be loss of a person, loss of status, loss of academic achievements. So that's loss and grief issues. So these are the three most common issues when students need your help. And the other things which is not uncommon and it is commoner than most people think is substance abuse within the students. Substance abuse can be in the form of can be with alcohol, it can be with sleeping tablets, or substance abuse also now includes internet addictions and some gambling sites. So it need not be substance in the form of chemical substance. It can be any other addictive behavior that have an influence on their overall academic and personal life. And the medically unexplained physical symptoms, commonest example is tension headache. People may say they can't concentrate because of tension headache or other form of physical symptoms. They may go for extensive medical investigations, and the doctors may say there is absolutely nothing wrong with the body. The person suffering is real. So that's where the psychological understanding is needed. It's not them making the pain. The tension headache is real. The headache is real. But the reason is the psychological stress causing the scalp muscles to contract, and that causes the pain. And that will not relieve unless the overall the stress management is improved. And this cannot be that headache cannot be seen by any scan, any blood investigations. So they will remain medically unexplained. But anyone who has experienced a tension headache or a tension migraine can explain how severe and how real the suffering is. So medically unexplained physical symptoms can impair student performance, and that cannot be helped by medical specialists. It needs intervention within the school or college setting. And there are more than 400 different psychiatric disorders, but they are broadly grouped into common mental disorders and severe mental disorders. Severe mental disorders are rare, and they make only 2% of all psychiatric disorders. Severe mental disorders they have more biological basis, and they are usually treated in specialist settings. But the common mental disorders like stress, anxiety, and depression problems are commonly dealt with in the setting where the problem presents itself, either by intervention by teachers, pastoral counseling, or it's done at the level of some primary care interventions. So these are the common mental disorders, or the most prevalent psychiatric disorders. As I said, it's 98% of all mental health difficulties are common mental disorders, which may not need any medication, which are more evidence to psychological interventions efficacy in common mental disorders than medications efficacy in for treating them. So these are the common situations when your intervention may be needed, and that's why probably you need about psychological interventions. So there's the major three elements in the psychological intervention. So the psychotherapy you can't learn just by listening to this 1 hour presentation or by reading a book or just talking with one person. Usually the psychological intervention or considers a practice, like you practice law or you practice your teaching skills. You learn by direct face-to-face interaction with a person who needs your help, as also at the same time interaction with a supervisor who can reflect about your performance and help you to guide the process. So psychotherapy is learned by you being the therapist, having an interaction with the client, and you being have a relationship with the supervisor who reflects on your performance, and the supervisor will never directly meet the client. So the therapeutic relationship between the therapist and the client, if the supervisor meets the client, then the psychological intervention psychotherapy works. You understand the problem of the client, you deliver support to the client with the support of the supervisor who remain behind the screens. And the purpose of psychotherapy can be either supportive, and that is useful when the problem is usually temporary. If a problem is just related to one exam loss or one transient problem, which you think that this will just pass in time, then supporting element is okay. You let the person to take time, sit back, reflect, and let his own inner resources and healing mechanism to get over the situation. So that is the supportive form of psychological intervention. Some psychological intervention need educative elements. So specific techniques to be taught, to how to manage the negative thoughts and how to develop the positive thinking habits and other mechanisms, relaxation mechanisms to cope with the anxiety and so on. That's educated. And sometimes people have learned maladaptive mechanisms, the mechanisms that will not work for themselves and that may be counterproductive to what they want to achieve. So then identifying those maladaptive mechanisms, identifying the which makes them maladaptive and correcting them is necessary for the progress. And sometimes it goes further in depth, the reconstructive. So the problem is not a short passing problem, and it cannot be corrected just by teaching an intervention or correcting what has learned in a wrong way. But we may need to go into the further in-depth, reconstructive, and understanding their own personality, the profile, and try to change. Usually, in the teaching settings or in primary care community settings, supportive, educative, corrective are the things you can practice on your own. When it goes into reconstructive domain, you may need clinical support. So I reiterate that 90% of the interventions can be given by the teachers for the students, and only 10 or less percentage will need help from specialist support. So these are the basic principles I initially highlighted. They've been known to psychiatrists and psychotherapists, counselors for more than 35 years. It's not commonly known as common elements or non-specific factors in psychotherapy. So it's like literature came first, and then it led to the grammar development. Various schools of psychotherapy came first, And psychotherapy research came next, and it shown that most of the school of psychotherapy are similar in their results, and they perform equally good. Then people started investigating what are the common elements which are working common in all psychotherapies, which may contribute to the benefit. And that's how people end up in making this list. There are 8 elements which are common for all different schools of psychotherapy. And if you practice these 8 elements correctly, that's more than half the job is well done. And the specific schools of psychotherapy only add on to the remaining 50 or less percentage. So the first part is the therapeutic relationship. And I cannot overemphasize this point, especially if you're dealing with youth and adolescents. People don't listen unless they trust you, respect you, and they like you. So the therapeutic relationship is the backbone of anything you want to achieve. So first, developing the trust in the person whom you are working with, and they think that you are a person who is genuine, willing to listen to their problem, and willing to help them, and you are not judging them, and you are not there just to lead them into a specific path that would you want to take. That is the advice, but helping them to find their own solution. So that sort of trusting, empathetic relationship, and you need to clearly differentiate between empathy and sympathy. Sympathy is when they are being sympathetic about and getting emotionally involved in someone's problem. Empathy is just understanding their problems, viewing the problems from their shoes. That's what empathy is. And empathy is good, and sympathy is often counterproductive in therapeutic relationship. So therapeutic relationship is the first common element. That's the backbone in any form of psychotherapy. And second is the therapeutic optimism. That's the age-old technique from traditional medicine. If you don't believe, if you don't promote hope, nothing works. So if you approach with anything with nihilism, not hoping to work, it's just not going to work. And that optimism will come only if you have trust. So trust comes first, and then hope and belief. So develop the relationship first, then instill optimism, instill hope, instill trust, and then you start working on something. And let the person to ventilate. Don't do the talking first, and let the people to talk and ventilate whatever they want to tell first. And when they are almost feeling that they have completed talking and they have not much to talk, they need to think, they left their pressure out. That's the time you need to start talking. So don't start doing the intervention in a pressure cooker situation, which may become counterproductive and things may explode, and that's not good for everyone. So ventilation of emotion is the third most important factor in any psychological intervention. And the fourth one is active listening. When someone is ventilating their emotions, our body language can easily put them off. If you just lean back, yawn, with one facial expression, looking into your watch, turning your head, looking into your mobile, that closes the conversation. Then you are whatever volumes of psychotherapy book you have read and whatever good intention you have, that may not work if you are not a good listener. So the active listening is a method. You maintain silence, but you talk non-verbally. Your body language talks, leaning towards the person, making eye contact at appropriate time, and nodding, and some non-semantic sounds you make. So that will help in the person to keep talking and make sure that you are actively listening. You are interested in their story, and you are. So that active listening is an important skill that is common in all forms of psychotherapy. And that's the empathetic understanding. So you don't start talking unless you have at least some grasp of what's going on. What is the person they're dealing with, and trying to view the problem from their shoes. You might have read about the transference and counter-transference issues in psychology. So it's quite easy that the human brain works with pattern recognition. When we see some person's problem or when they describe the problem, we always try to compare the experiences we have had in our life. And that's the transference issues. And we try to use our brain's pattern recognition mechanism to fit a particular class which you understand well. But that's good at a certain time when you know the culture very well and when you know the person very well, and it may not work when you're trying to understand a new person. So begin with a clean slate and be empathetic. Try your best to view the problem from the person's own shoes, and you need to understand their problem and make them believe that they understand they understand that you understand them. So that should become obvious in the interaction that you are making genuine attempt to understand them. And then at the sixth point comes up with an explanation of therapeutic rationale. So every school of psychotherapy has a specific way about starting the problem, and that has to be clearly spelled out to the person who is receiving it. Otherwise, they may think that it's all about they listen to your problem and he's a good person, but they are not doing anything. So you need to clearly explain what does work, what will work, and what they need to do for work. Leads to the next stage. May say that it's not just relieving distress, that should be a behavioral change. So some psychotherapists just stop with making the person feel better for momentarily, but that's something can be achieved by a counselor or even a good entertainment movie. So that's not the work of psychotherapists. Psychotherapists emphasize behavioral change. A particular element of behavior should change, and to that become some maladaptive behavior should change into adaptive behavior. And the eighth part is the most important part. If this is not done, it's almost a chance of failure, and there's a risk of anger and frustration turning towards the therapist. That's the earliest possible opportunity. There should be an element of sharing the responsibility. You might have seen this very well in traditional healers and faith healers. They usually give a lot of tasks. You need to follow this many days. You should not eat this, and the eating restrictions and a lot of physical activities, avoiding things, waking up time. They give a lot of tasks for the person and then provide an intervention. So the responsibility for improvement is mutually shared. Same here. So you don't take as a part of a magic healer who solve all the problems. Instead, you say that we work towards a solution, and I have some responsibility to guide you, and you have a responsibility to carry them out. And if one of us not performing our responsibility to the expected extent, then we won't achieve the expected results. So that message should clearly go in the very beginning of the interaction, and that should be highlighted in every passing session. So quickly going through the list, there should be a very supportive relationship. That's the main backbone. And once that trust, hope, that instill optimism, belief, and allow the person to ventilate their emotions, use and develop your active listening skills, and try to understand the person from their own shoes and make them to see that you are understanding their problems, and explain a clear therapeutic rationale about how things may work, and emphasize the behavioral change and share the responsibility for improvement. Do you still see my slides? Do you still see my slides?
Yes, sir.
Excellent. So the basic principles continue. So again, I'm highlighting the most important basic principle, or psychotherapy is developing the principles of counseling. So the basic principles of counseling still exist in psychotherapy. So it should be non-judgmental, non-directive. So you are not there to judge someone what is doing there, good or bad, right or wrong. People may have completely different viewpoints from what you have. They may have completely different faith, and culturally what you think is completely not acceptable may be acceptable to them. Please don't judge. If you are judging, that's the first element you need to correct before becoming a good psychotherapist. Similarly, advice is freely available all over the world. and everyone has a tendency to advise and give solutions to other problem. And until you master the ability to control this basic human instinct of giving advice and to learning to be non-directive, it's difficult to be a psychotherapist. And please remember that advice is often counterproductive when it is given in a non-trusting relationship. People may easily say that you don't understand my problem, and that's why you say this. And that this because you are in a privileged position, you say this. So advice is often counterproductive unless you have built a therapeutic relationship and you have proven empathetic understanding and active listening skills. It's not going to work. And basic principle, it is a collaborative relationship. Psychotherapy is a collaborative relationship. It's not one person solving another person's problem. It is two people working towards betterment of one. And don't think about specific psychiatric diagnosis. That's the job left to the actively working clinical psychologists and psychiatrists. And they actually need to see only the less than 10% of people you are dealing with. Psychotherapy is just not talking. I'll also highlight this in one of the later slides. There is a lot of evidence that psychotherapy does make changes in the brain, and it makes the ways as how the brain cells communicate with each other, and the brain's neural synapses are modified because of just by talking. So brain is quite a dynamic structure, and psychotherapy is fixing the bugs in a software. So it's not the neurologist who is seeing into the hard wires to fix the problem. It's like computer example. It's like the doctors are dealing with hardware and the psychotherapists are dealing with the software. So most of our problem you deal with the students are the software issues, mind related issues, and there is good evidence that talking therapy can make behavioral changes. So be confident about what you deliver. Various schools of psychology. That's a huge history of psychology, and each school has a lot of names and a lot of theories to talk about. I'm not going to go into those details now. They will be available in your textbooks. I'm just going to mention their names and how they are related to different schools of psychotherapy. So the earliest idea in psychology is the structuralism, where people made attempts to break the complex human mind into smaller structures and trying to assign specific function into structures. So the whole is broken into parts and trying to understand the parts. That's structuralism. And the functionalism is people trying to understand how the brain overall works. So instead of focusing on the structure of the brain, the brain worked or a mind worked into specific cognitive activities and leading into specific functions. So these are the two major schools of psychology in the earliest 100 years ago. And that set the stage for different psychology. Still, there are different schools of psychology which focus on parts, and there are different schools of psychology that focus on the whole psychological experience. So the earliest school of psychology is psychoanalysis, with the famous name of Sigmund Freud. And Sigmund Freud is not a psychologist. Sigmund Freud is not a psychiatrist. He was a neurologist, and he worked with the elite class in 19th century Western Europe. So he saw totally different people with be deal with, and he made some theories, structural theories, which are very famous and we probably still use in our day-to-day life, like ego and unconscious mind, subconscious mind. These are all written by Sigmund Freud. They still exist only in theory, and there's no scientific proof for existence of ego, superego, but still it is used in a form of therapy. So psychoanalysis is usually not used for any common day-to-day life problems. It is a mechanism for understanding one's own personality, how it is developed. Usually it goes for weekly or context for 2 to 3 years or even longer until a person develops an insight about his own personality and how his personality developed. So psychoanalysis is otherwise called as insight-oriented. Psychoanalysis came with an idea. Sigmund Freud thought that our personality was fixed at the age of 5 because of a lot of his theories he made, and people don't change after the age of 5. Whatever anxiety and behavior problems you experience towards the later life, all are determined by that what happened to you before the age of 5. It's called psychic determinism. So the psychodynamic theorists who came after that, but that's not true. People may change if they have better experience later in their life, and how their mind work may change after the age of 5. So that's the psychodynamic theorist. There are various schools of psychodynamic theorists who emphasized on still a thought of insight, letting people to understand their own problem. And they believe that by having that understanding, that changes their behavior. So that's the commonality between psychoanalysis and psychodynamic. Differences, psychoanalysis thought people won't change after the age of 5. Psychodynamic thought people keep changing their life. And a drastically different school, but it's a very old school, more than 100-year-old school, is the behavioral school. And you might have taken your psychology textbooks, 2 schools of behavioral psychology, operant conditioning and classical conditioning. So classical conditioning explains some anxiety disorders, phobias, and operant conditioning works on almost everything. The reward and reinforcement principles are used for shaping behavior throughout all the setting in business management, making you to purchase certain things. So this is commonly used by the marketing people now than the clinical people. So the behavioral school is based on the Skinner's work and Paulo, and that's the behavioral school. And there is a school of psychology called Gestalt psychology, which comes more from the functional school, thinks about the whole is more than the sum of the parts. And there's a difference between Gestalt psychology and Gestalt psychotherapy. So Gestalt psychotherapy works more on, it borrows only a few elements from Gestalt psychology, but it works more on the person's current experience here and now. And correcting the current experience will correct their overall personality. That's the way that Gestalt works. And the cognitive therapy emerged in the late 1950s. And the cognitive therapies works on making the thoughts as the most important modality of treatment. So emotion do not have form, thought have form. Thought comes with one's own native language. So we can't change emotions at our will, but we can monitor thought and correct it. So that's the purpose of cognitive therapy. And currently, cognitive behavior therapy are the most widely used therapies all over the world. And humanistic form of therapy, you know about more complex theory, Maslow's hierarchy, and other different humanistic school of psychology, and they lead into existential therapies and cognitive analytic therapy and different schools of psychotherapy. So if you read your schools of psychology from your psychology textbook, they are roughly related to the schools of psychotherapy. And more importantly, there is something called eclectic therapy. The eclectic therapy is like a mixture of different techniques. Because when the schools of psychology formed, they were almost like religion. People who fit into the school, they believe that whatever they believe is correct and everyone else is wrong. So they were fighting with each other. There are huge, famous letters and enmities between the different schools of within the school of psychodynamic. But currently, people understand that we don't need to be loyal to any single school, and every person we see is different. So we may take elements from different school, and whatever work for our client, we may use it. That's called the eclectic form of approach. So currently, most of the psychotherapies are eclectic therapies or cognitive behavior therapies. But you need to know these elements because this gives you the armory to deal with the person in front of you. So the psychotherapies or supportive psychotherapy is the one just focusing on the common 8 factors, provide a support and let the person to get difficult time. Behavior therapy works on the reward reinforcement. Cognitive therapy focusing on how the person thinks and trying to correct the way they think and then enforce the change in their emotions. So cognitive therapy emerged in the 1950s, and then the rational emotive therapy, a person called Albert Willis, who found the relation between thinking and emotions and how the dysfunctional assumptions we have in our mind that influence the way we think and how we feel. So by challenging our inner beliefs, we found a way to change our thinking ways as well as we regulate our emotions. And that was the first therapy that dealt with behavioral changes by dealing with, and that led to the current cognitive behavior therapy. So cognitive behavior therapy is introduced by a person called Aaron Beck in 1960s. And currently that's the most evidence-based, widely practiced therapy. It's not because it is superior to other therapies, because it can be easily manualized. So I can print a book and give you this what you need to do in each session, which cannot be done in other therapies that easily. And when it can be manualized, it can be evaluated in clinical trials to find out whether it is working or not. So we can produce research evidence for that. So cognitive behavior therapy has more research evidence than any form of psychotherapy. So it gets more funding than any form of psychotherapy. And the principles of cognitive behavior therapy can be practiced by anyone. There are computerized cognitive behavior therapies now, where the artificial intelligence actually delivers the therapy. So yeah, teacher can definitely deliver it. Any human can deliver cognitive behavior therapy if you're motivated enough to learn the. And there are self-directed cognitive behavior therapies by reading the manual and going through some computer softwares. People can try to treat their own anxiety in the early stages. Still, psychodynamic psychotherapy exists, but because of the time involved and the motivation of the person to stay in the treatment for years together, it is very rarely practiced even on the specialist settings. And combining the psychoanalytic theory and the cognitive theory, there's another therapy called cognitive analytic therapy that's still practiced. And the therapies I have listed so far are all individual one-to-one therapies. But there are therapies that deal with couples, family, and groups. So group therapy, I'll reserve another slide for the group therapy. But the couple therapy and family therapy, where the individuals are not considered as the clients, the overall relationship between them is considered as a client. So when a couple comes for a treatment, it's not just for the the couple can be student's parents. It's not the father or the mother who's seeking help, but the relationship between them or the relationship between them and the child. That's the family therapy that needs intervention. So I'm just giving one slide on the cognitive behavior therapy, because that may give an idea about how cognitive behavior therapy works and how the difference. Just one example for how different specialist psychotherapy techniques work. So CBT is commonly used to manage anxiety or depression. So the CBT rationale is, by controlling thoughts, we can control our emotions. By changing our thoughts, we can change our emotions. So that's the CBT rationale. In a simple form of CBT, basic form of CBT, it starts with asking a person to monitor their own thinking. So maintain a thought diary, which is quite personal. They don't need to share with the therapist, but just try to document when they are alone, what their mind think. When they're happy, what their mind think. When they are sad, what they're trying to write. And then see when they are out of that emotion, try to see how their mind think at that time. So that's called thought diary. And usually when a person is feeling low, there will be a lot of negative thinking documented in that diary. And the negative thoughts will come automatically. They are called negative automatic thoughts. It's like, I'm a failure, I'm good for nothing, and nobody likes me, and I haven't done anything useful. There's no point in me living. These are all the negative automatic thoughts. So once we identify the negative automatic thoughts in the thought diary, highlighting it, then we will go into what are the assumptions. You'll try to challenge the person, try to find explanation for the person. Why do you say nobody likes it? Nobody likes you. The person may say that one particular person said on a particular occasion this, that's why I think nobody likes me. Then we'll ask that, has anyone else said good things about you? There will be definitely a few occasions in the someone has said good things about you. And is there any need for everyone to love, like you? There is no. So there is a certain assumptions that everyone should love like me. Everyone should talk only good things about me. So that's the assumption behind that leads on to this negative thoughts. So from the thoughts, we try to explore and reach them. What is the assumption? I need to be successful in everything. Otherwise, people don't like me. So that may be the assumption that leads to the negative thoughts. I'm a failure. Nobody likes me. So from the thoughts, progress to our assumption and try to challenge the assumption and try to highlight the irrationalities in that assumption and to try the person to bring to more realistic way. And then emphasizing a behavioral change. So once the assumption is challenged, then we'll try to form alternative positive thoughts. We'll tell them that negative thoughts are so much practice. It's like a whirlpool going in a particular direction. It is taking you down. If you're trying to challenge that, if the water is spinning on one direction, if you're trying to change the direction, there will be turmoil in the beginning. But when you keep spinning on the opposite direction, soon the whirlpool will be on the positive side. There will be positive automatic thoughts replacing the negative automatic thoughts. So that will be the stages of recovery. There will be turmoil. There will be a stage where you can instill positive thoughts only by a lot of effort. But soon you can turn the direction of the spin of the water. Same here, the negative automatic thoughts can be changed to positive automatic thoughts. And that can lead into the way the person believes. And we can believe and how they feel, but we can't measure someone how they feel. What we can measure is what they do. So how they act, some goals, behavioral goals we need to set and assess whether the person is able to achieve this goal. If they are not achieving the goal, we need to go back to this process. Are we missing some other negative thoughts and making the person still feeling low? This is how the cognitive behavior therapy session works. And you may use these principles even without a formal cognitive behavior therapy session in your own life, in dealing with your own. Finding your own automatic, negative automatic thoughts, identifying the underlying assumption and challenging the assumption and trying to replace them with positive thoughts, initially dealing with some turmoil, then with the willful effort to replace positive thoughts, and then setting your own goals as a behavioral goals and see whether you are progressing in the right direction. So there is the supportive psychotherapy that's commonly used in other setting, outside clinics, probably in school settings. There's a simplified form of 10 steps protocol is given as a supportive psychotherapy published from the protocol. This mirrors the 8 common factors I highlighted earlier. So they work on the similar principles, but they are more manualized and further detailed. Whole book available on this 10 steps protocol. I'm going to mention them in just 2 slides. So supportive psychotherapy works with acknowledging the distress and what they are experiencing. This shown this 10-step protocol is quite useful in managing this medically unexplained symptoms, the tension, headaches, and other physical symptoms that may impair a person's ability to engage in academic work. There's some evidence, research evidence to support that. So this may be useful for the students who are reporting such specific issues. So acknowledging the person distress, saying that the tension headache is real for them. They are not making up the headache. If you're thinking that you're saying that the headache, all the reports are fine, why do you think you have the problem? Then you are not going to progress anywhere in that supportive psychotherapy. So first, acknowledge distress and what they think the problem is. They may not say this is tension headache. They may say, I may have a serious tumor, that doctors are missing it. Or they may have a serious disease, that doctors are missing it. So try to understand what they think. And then give a clear explanation about their fear. That's not saying that there's nothing wrong with you. You think a tumor should have seen in the brain scan. The doctor has done the scan and the doctor has said that you don't have that. This headache can happen because of tension headache about the stress you're going through. So try to shift the focus from body to the actual in their life and provide specific reassurance. You can't give reassurance, a specific problem. You don't have this problem, but you may have this problem. Only you do the second step, understand what their problem is. And then discuss alternative explanation, how stress may cause pain and how stress may cause acidity, how stress may cause abdominal symptoms, and stress can lead into other physical abnormalities in the human body. So discuss about how the cortisol system work and how the stress reactions work, stress hormones in the body. So that's the alternate explanations we can provide. And there are some culturally sanctioned interventions. People believe that going into certain religious things may fix them. And taking some faith-less medicine with them, don't contradict them. We are not fighting against any beliefs. We are working towards the betterment of a person. So all are culturally sanctioned interventions, but tell them that that should be done while the person taking the responsibility for their own improvement. So that's not a magical cure. So it is a part of the intervention. And if that makes them feel better, they can do it, but they do not put their whole, all eggs in that basket. And then suggest general coping strategies like adequate sleep, eating healthy, general exercise, taking some break for other, and then specific stress reduction, whatever specific thing bothers them. If it's a relationship issue, you need to deal with the relationship pathway. If it's a loss issue, we need to discuss with the loss pathway. If it's a depression, we need to deal with that specific issue. And the most important is sharing of what I mentioned earlier, and provide a specific appointment. So most of the talking sessions will not end in one session. And when you establish a relationship, the person is going to come back to you. And you need to clearly set the boundaries in the beginning. Otherwise, the person will think that everybody gives hope beginning, but then they turn their back to me, and nobody helps me in long term. So if you provide a specific follow-up appointment, it can be once in 2 weeks or once in a month. That can prevent the person contacting you in between. And it is not professionally acceptable to share personal contact information, personal emails, personal mobile number, WhatsApp number to a person you are doing therapy with. That's clear breach of professional boundaries. A clinical psychiatrist by profession oath, it's not supposed to do that. Same you need to follow if you want to be a therapist. So maintain professional boundaries and provide specific follow-up appointments. And any problem can be dealt on the specific follow-up appointment, not on the physicals in between. So there are different schools of group therapies. I'm just going to cover them in one slide. So the group therapy differs from individual therapy because it deals with groups rather than a person, and it is quite effective in academic settings. The role of the group moderator, instead of a therapist, is called as moderator in a group. It's similar to the individual therapist, a non-directed, non-judgmental person who encourage others to talk, find their own solution, not providing advice. There are different types of groups, which are open groups, continue to recruit people with their different sessions. So there will be different people attending the different group session, or closed groups, same people attending repeatedly. Groups can be homogeneous, a specific person, all boys group, all girls group, all people of a particular age, similar problem, go to a homogeneous group, or a different people heterogeneous. And in group therapy, people learn a lot from understanding their problems. Some problems which may be huge when we think we are the only person suffering it. We feel better. We feel better when we realize that it's not that we are the only people, the other people do that. People may learn a lot of good things from the peers. People can learn bad things from the peers. So we need, the moderator job is to highlight what are the adaptive and maladaptive, which works, which doesn't work, not judging anyone whether they are doing right or wrong. And group therapy thrive on communication and support. And like individual psychotherapy, there are different schools of group therapy. Supportive groups, cognitive behavior therapy groups, behavioral groups, and cognitive analytic groups, and psychodynamic and psychoanalytic groups are available.
Sir, your voice is muted.
Can you hear me now? So the family therapy, it deals with the individuals. It's a family as a unit. And at the beginning, you need to clearly identify it's not about treating an individual, but their relationship issues. And there are different schools of family therapy. That's a whole array of family therapy mechanisms are available, especially in child and adolescent setting, but it's also relevant to the youth interventions. So systemic family therapies work as a first parent and child system. Then there are supra systems with the outside family members and subsystem within the marital couple and siblings. So that's a system-based approach. Structural approach is dealing with the hierarchies. Strategic is how the family try to resolve their problems and improve their communication. Each school of family therapy has its own founder, its own practitioners, its own theory, and its own textbook. So I'm not going into further details. And there are psychodynamic and cognitive behavioral based family therapies, and family therapies focus on communication and experiential aspects of how we can correct the current experience that will lead into the change in the behavior. So there are different schools of family therapy, different school of psychotherapy. I'm going to allow a few slides to the common problems, and then we can draw to a close. So the grief, you may be well aware of the Elizabeth Kubler-Ross 5 stages of grief: denial, anger, bargaining, depression, and acceptance. And the student you deal with can be in any of these stages, depending on how important the loss in their life and how abrupt the loss happened in their life. So most important thing in grief intervention is be with them. You don't need to do any active intervention. Time will heal. Understand which stage of grief they are in and to roll with them and try to promote their own inner strength. I learned a lot in grief counseling by dealing with the tsunami survivors in 2004. I was working in a CMC Vellore, Christian Medical College Vellore then. And our findings were published in Viria. It's one of my earliest paper in 2008. Even people who had 4 children, lost all 4 children, could recover without any major psychopathology after 6 months, because of a lot of cultural coping strategies and family values. I'm not going into those details now, but people have extraordinary resources within them to deal with their loss events. So promoting their own resilience and being with them, giving them that to heal and encourage them to deal with their difficult times in their life. That's the core of grief counseling. This protocol for motivational interview is initially designed for dealing with people with alcohol problems, and it can also be used for anyone with any sort of behavioral addictions. As we mentioned, the idea behavioral addictions now includes internet addictions and gaming, social media. Motivational interview. So the acronym is known as DARS. So first, let the person to develop a cognitive dissonance, see what they actually perceive and what they actually are, and try to instill dissonance within them, and then they make them to recognize there is a problem. So that's the first step, developing a discrepancy. Second step, avoid arguments. Don't argue with the person. Rolling with the person will minimize their problems, doesn't want to change. Everyone doesn't want to come out of their comfort zones. So don't push any change, but recognize the resistance and discuss about the resistance and gradually work with them to develop the motivation within themselves and express empathy. Probably at the time you do the motivational interview, everybody views them as villain in their family and their society. So tell them that you understand their problem and they are actually victims, and express the empathy and support their self-efficacy. Tell them that you are better than this and you have resources to do things better, and you are doing this not for the sake of others who are telling you to change, it's for your own betterment. So that's the principle of DARS, motivational interview, routinely used in substance abuse settings, but quite relevant to deal with the behavioral addictions in school settings. So just, this is my penultimate slide. You need to get an understanding that depression is commonly misused word. Everyone who feels sad often says they are depressed, but depression and being sad are not one and the same. Being sad is a feeling. It is a symptom. Depression is a clinical syndrome. There is a specific diagnostic criteria for depression. That's a 10-item criteria with 3 major factors and 7 minor factors. And these factors are listed in the World Health Organization's International Classification of Diseases. And doctors use that criteria to diagnose depression. And if a person has certain number of symptoms for more than 2 weeks, persistent low mood, then only they call it as depression. So don't think every sadness, every human sadness is depression. Depression has very specific symptoms, and the severe mental disorders, which in the specialist settings deal with, they have different forms of depression. So you may not deal with depression in your setting, and not everyone who says depressed are actually depressed. They are actually distressed, they are seeking help, and you can provide that help. They don't need a referral to a psychiatrist. But then you need to refer. I come to the psychotherapy research. So then you need to refer when the person start talking about harming self or any talk about suicide. That's the first hint. You need to stop talking, doing the intervention. This person may need specialist help. And one important thing I haven't mentioned so far, but assumed in any counseling is confidentiality. You can't open that information to share with others. But when there is a clear risk of self to others, it is okay to break confidentiality, but it should be told on the beginning that if there is a clear risk, we may need to, that's the limits of the confidentiality should be disclosed at the beginning of the intervention. So when you sense some suicidal risk of self-harm, you should disclose to others and seek help for specialist support. And when you think the substance problem, it's not just at the level of the beginning of the problem, the person is quite addicted, fully dependent, their whole life is depending on this, then probably after the motivational interview, you need to seek help from a specialist setting. And when there are some false, unshakable beliefs that are not amenable to reason and that cannot be challenged, the person strongly hold on to a belief. My nose is completely disfigured, and everyone is making fun of that. And this is because someone has done something to me. And that belief it cannot change at all. And if that colors their whole life, this is called a delusion. And that needs itself, if you suspect a delusion, that's a form of psychosis that needs medication treatment. So that needs referral. And if a person reports having experiences, hearing voices, seeing things which do not exist, which others can't see, there is a problem that needs referral. And you start dealing with an interpersonal problem, but if it's quite incapacitating, quite in-depth, you don't have time for that, or you feel that this is out of my expertise, my supervisor's expertise, you need to refer. When the person is talking about harming others, or when the person is talking about they are being harmed by others, some form of domestic violence, then you need to involve other services. So risk of harm to self, others, from others, psychosis, substance dependence, and when they are quite a complex interpersonal problem, that's the time you need to seek help from others. So I stop here. We have some 4-5 minutes left. I'll leave the time for some question and answers. We have been so quiet so far, so please use this time. I know that you are a class coming up very soon. If you have time, please feel free to ask questions.
Dear participants, utilize this golden opportunity. Sir is waiting here for interaction.
I have displayed the title page again. That's my email address. So we have covered a vast topic in a very short time. So I'm sure there will be further questions, and feel free to ask the question by email if you wish later. I'm available here. I'm actually available for under 15 minutes, but I know that you need to leave earlier than that. So please feel free to ask anything related to psychotherapy.
Good afternoon, sir.
Yes.
I am Sivaranjani. As a need of, as a teacher, how can I identify student about the need of a psychotherapist, sir.
As a teacher, you will see their academic performance. You may see their change of personality, how they behave with the peers and how they participate in the class. If you find there is a difference, the first step is you will ask them in private what is going on. Do they recognize a difference? Do they recognize the difference in themselves? And do they think that they need help? If they think they are in problem and they need their help, that's the point you should consider psychotherapy. So usually it starts at the level of counseling. But if you think the problems are more complex, you need to consider psychotherapy. Was that audible? I get a lot of echo. So could you hear that? Hello. Could you hear that? I'm not sure whether you hear it because I get a lot of echo. Sivaranjani, hear me, sir? Thank you.
Participants, can we consider that you have absolute clarity? We are waiting for your interaction. Okay.
I think you have another session in another 10 minutes. People
I
are
can
getting.
feel how our minds.
I'm sorry, was there another question?
So thank you for your presence, sir. I can understand the hard work, how much you have worked hard for all these achievements. Really, it was motivating and inspiring. Right from your CV, when we saw, we could understand how far we have to go still in the field of research and also in the whatever field we are. We have to achieve a lot, and we have taken a lot of strides to take every step ahead. So that we are very happy to have you here. And we are really impressed with the way, in very simple terms, of course, it is a very tough topic for us to follow, but considering the overview of psychotherapy in a very elegant way, you explained it. We felt like being as students here seated so that we can receive the input from you. So that thank you for being with us on this day. And also you gave your gracious consent when we approached from the college to get your acceptance for providing a session for us. It was indeed a very valuable session. And on behalf of the ICM management and also the management of St.Ignatius College of Education, we owe you a lot for the efforts you have taken to enrich all the participants here in this virtual gathering. And students from different colleges and also from different universities are here. And everyone might have felt that psychotherapy is not far away. It is a part of their life to enrich themselves. So that thank you so much, sir. And let us continue the session, please.
Thank you very much. And thank you for the opportunity. See you, everyone. Bye.
I could feel how our minds are enriched with knowledge we gained through the webinar and heartfelt with gratitude. Silent gratitude isn't it much to anymore. I'd like to call upon my friend, Ms. K. Sivaranjani, student teacher, to deliver the word of thanks.
Resourceful mind dwells in grateful soul. Any deed would become meaningful and complete only if it is given or received with gratitude. A very good evening to one and all present here. It gives me an immense pleasure to deliver the vote of thanks for this event to all the dignitaries present here. I would like to thank our beloved Secretary, Reverend Sister A. Gemma, for the support, and it's my great privilege to thank our dynamic principal, Reverend Sister Dr. L. Vasanthi Madana for her encouragement and blessings for the successful program. I would extend my heartfelt thanks to our resource person, Dr. Anto P. Rajkumar, for enlightening us with his knowledge. Today's webinar was full of interesting things and about psychology. It gave deep insights into the topic and also revealed many new facts. The idea shared by Dr. Anto P. Rajkumar has about the 8 common factors of psychotherapy was really informative. I am pretty sure the precious knowledge that you gave us will definitely help us in our studies and future endeavor. Once again, I would like to thank Dr. P. Rajkumar for his sparing his time from busy schedule, enlightening us with knowledge. Thank you so much, sir. It's my delight to thank our Reverend Sister Dr. A. Nirmala Devi, former Principal and Assistant Professor of Education, Dr. A.C. Punitha, Dean and Associate Professor of English, Dr. M. Maria Saroja, Research Director and Associate Professor of Biological Science, Dr. N. Tarasida Shanti, Controller of Examination and Assistant Professor of Physical Science, Dr. R. Indra Mary Eril Selvi, IQAC Coordinator and Assistant Professor of Psychology, Dr. A. Jayasudha, Vice Principal and Assistant Professor of History, Dr. J. Maria Prema, Assistant Professor of Education, Dr. S. Josephine, Director of Physical Education, Dr. P. Jansi Rose, Librarian, and all the teaching faculty of our college. Next, I would like to thank our organizing secretaries, Dr. R. Indra Mary L. Selvi and Mrs. A. Lily Maria Pravina. Thank you so much for organizing such a wonderful webinar, professors. And also I thank all the students participated here for this webinar, making interactive and lively. Thank you so much.
Thank you, Sivaranjani and participants for being with us to make the event a successful one. Let us proceed after 15 minutes with a paper presentation session. So far now, thank you all.
Okay, participants, you have 3 different links, 2 Google Meet and also one that is in the same Zoom link. So you can join in any one of the parallel session so that you can also participate in the paper presentation and you can observe how it goes on and your valuable suggestions are invited. So let us all meet again after 10 minutes break and let us be together at 3:30. And here in the chat box, the 3 links are posted so that you can note it down and at your own will and wish, you can choose any one of these links and you can be a part of the paper presentation session. It will be so valuable because most of the persons who are presenting the papers are research scholars and also learned educationists. So that utilize the opportunity and be present. Thank you. Now you can join after 10 minutes in any one of the link. The free choice is yours. Thank you. Good afternoon. Good afternoon.
Good afternoon, ma'am.
Sashi Priya, ma'am.
Good afternoon, ma'am. Ma'am, good afternoon.
Sashi Priya, ma'am.
Ma'am, I'm here.
Good afternoon, ma'am.
Good afternoon, ma'am.
Ma'am, please unmute yourself, ma'am. We are not able to hear you.
I already unmute, ma'am. Ma'am, may I audible now?
Participants, is anyone are able to hear ma'am's voice?
Yes, ma'am.
Okay, thank you. Ma'am, please you unmute your mic. Dear participants, am I audible?
Yes,
அவங்க
ma'am.
பேசுறாங்க ஆக்சுவலா அன்மியூட் பண்ணி தான்
Thank
இருக்காங்க
you, thank you.
பட் ஆனா நம்மளுக்கு கேட்க மாட்டேங்குது சோ அவங்க பார்ட்டிசிபென்ட்ஸ்க்கு கேக்குதுன்னு நினைக்கிறேன். We are not able to hear.
இல்ல மேம், இல்ல அப்படி சொல்லவே இல்லை. சொல்லுங்க.
எங்க வேணாலும் இல்ல பார்ட்டிசிபென்ட்ஸ் எங்க வேணா இதுக்கெல்லாம் சொன்னாங்க பேப்பர் பிரசன்ட் பண்றவங்க அங்கதான் வர சொல்லுங்க.
Ma'am, shall we start?
பேப்பர் பிரசன்ட் பண்றவங்க அந்த செஷன்
Dear participants, a kind request from the organizing team that here only 7 members are going to participate their papers in this Zoom meet. The remaining people has to present in their respective meets what they have given to you. Please, the remaining participants, those who are going to present the session in different Zoom or Google Meet, please go to their appropriate links and share your papers there. Here only 7 members, I think 7, no? 7 members are going to present paper here. The remaining people, please, the paper presenters, go to your respective Zoom Meet or Google Meet link and join the session and present your paper. Sashi Priya ma'am, very sorry, I'm not able to hear you, but the audience, the participants are able to hear you, I think so.
Okay, ma'am, no problem.
Okay, ma'am. Shall we start the session, ma'am?
Yes, ma'am.
Okay, ma'am. Okay, thank you so much, ma'am. Dear participants, here we have for the session, Dr. Sashi Priya, Assistant Professor of Physical Science from BOC College of Education, Thoothukudi. And she had a great profile, she guided 4 MPhil scholars and 13 MEd scholars. She had completed a minor project for SSA in Chennai in 2012 and has applied for many research projects. She has organized national workshops and seminars sponsored by UGC and college management. She is approved guide of Tamil Nadu Teacher Education University, Chennai. She is the initiator and editor of the research journal entitled EduReach, published by VOC College of Education. She is serving as a coordinator for MEd, IQAZ, and RUSA of the institution. She coordinates the computer courses level 1 for the basic learners and level 2 for the advanced learners to enhance the ICT skills of the student teachers for their teaching and learning process. She has written research articles in all the level of journals, in national, international, and online journals. And she has presented papers in all kind of conferences, workshops, and the seminars. So such a resourceful chairperson we are having for the session. Ma'am, we are so fortunate to welcome you for this paper presentation session, ma'am. Thank you so much. On behalf of our Ignatius College of Education, we are welcoming you, ma'am. Thank you so much, ma'am, for accepting our invitation.
Thank you, ma'am, for your nice introduction. Good evening to everyone gathered here. I am happy to be the chairperson for this paper presentation session. Nowadays, we are facing nuclear family and COVID-19. There are tremendous changes in the education system. So each and every individual should strengthen the mental health in their positive way. Here in the morning itself, we gained a lot of information about the positive mental health, and we are eager to gain more views from the participants. So it's time for the paper presentation session. Here, first I invite Ms. Shelva Meenakshi, research scholar, Manoormaniyam Sundanar University. She is going to present the paper on the sensation-seeking sway crime. Selva Meenakshi, are you here? Selva Meenakshi. And the next presenter is the S. Ramya, MEd scholar, St. Xavier's College of Education. The third paper presenter is Mrs. S. J. Mary, PhD scholar, Manoormaniyam Sundanar University. Ms. J. Mary, are you available? Are you here?
Yeah, ma'am. I'm here.
Thank you, ma'am. The fourth presenter is Mr. R. Bala Subramanian, research scholar, Tamil Nadu Open University.
Yes, madam. Good evening. I'm here, madam. Thank you.
Thank you, sir. The fifth presenter is Again, Selva Meenakshi. Yes, I think it is a repetition. The next presenter is the Vishwapriya, MSc Psychology, MS University. Ms. Vishwapriya? Vishwapriya, are you here? Yes, thank you.
Myself, Anupama, we are the members of Group 1, and Vishwapriya is also a member of our group.
Okay. The next presenter is
Anupama is going to present. So we all of 5 members are going to present today.
Oh, okay, wait, Vishwapriya. Thank you. The next presenter is the Mrs. Vinodini Sylvia, PhD scholar, St. Ignatius College of Education. Ma'am, are you here? Mrs. Vinodini Sylvia? Okay, now we have to start. Ms. Selva Meenakshi? The second presenter, I would like to invite S. Ramya, MS Scholar, St. Ignatius College of Education. Please share your presentation.
Sorry, ma'am, I'm from St. Xavier's College of Education.
Okay. S. Ramya from St. Xavier's College of Education. Please share your presentation.
Okay.
The presentation time duration is 5 minutes.
Here there is an information host disabled participants screen. Sorry.
Okay, ma'am.
I couldn't share my.
Yes.
Yes, ma'am. Yes, ma'am. I can make you as a co-host, okay?
Oh, okay, ma'am. Okay, ma'am. Thank you, ma'am.
Okay, okay. Ramya, now you're as a co-host. Now you can share the screen.
Okay, ma'am. Thank you.
Yes.
Is this visible, ma'am?
Yeah, it is visible, Ramya.
Okay, ma'am. Thank you, ma'am. Thank you. Okay. Good evening to one and all. I am Ramya, doing MEd second year in St. Xavier's College of Education. First of all, I would like to thank my Lord Almighty for giving this opportunity. I would like to thank ICM, principal sister and staff for organizing this worthwhile platform. And then I would like to thank St. Xavier's College of Education's principal, staffs and my partners and guides, Dr. A. Michael J. Leo and Dr. M. Anthony Raj sir, for their conservative criticism and motivation. I feel pleasure to present my paper in front of the chairperson, Dr. R. Sasi Priya, IQAC coordinator, VOC College of Education, Tuticorin. And my topic is mental health of Zoomers, a cleansing analysis. This is a brief note of my abstract. The purpose of this thematic paper is to find out the mental health of Zoomers and to cleanse it. Zoomers refer to the generation born roughly between 1997 and 2012. They're the first generation to be completely raised. They are the first generation to be completely raised with the internet and smartphones and have grown up with the different experiences of the world than previous generations. One aspect of technology that is widely used by Zoomers is social media. Then my keywords are mental health, positive and poor mental health, then Zoomers and social media.
Yeah. In the second session,
and then mental health. A brief note on mental health. Mental health is the term used to describe how well the individual is adjusted with his own self and harmony with those around him. He is able to meet his problems without many disturbances, and his fears and anxieties are always normal, says Goldenson in 1984. In the book entitled Mental Hygiene in Public Health, P.K. Levkin has written that a mentally healthy individual is one who is himself satisfied lives peacefully with his neighbors, makes healthy citizens of his children, and even after performing these fundamental duties, has enough energy left to do something of benefit to society. And then there are a few points related to characteristics of a mentally healthy person. A mentally healthy person has maintained a balance in their lifestyle. He or she possesses socially adaptable behaviors. They are emotionally satisfied, enthusiastic and reasonable, and then possesses good habits and constructive attitude. Psychologically, healthy person does not live in a past, but he always plans and thinks for future and acts accordingly in the present, says Shashi Prabha Sharma in 2006. And then about positive mental health. Positive mental health, according to the World Health Organization, is defined as a state of well-being where individuals are able to realize their own potential, work productively, cope with the normal stresses of life. Positive mental health isn't just the absence of mental health problems. It is about mentally or emotionally healthy, is much more than being free of depression, anxiety, or other psychological issues, says Valentine in 2003. And then characteristics of mentally healthy person. Characteristics of positive mental health. Positive mental health is characterized by a person's ability to fulfill a number of key functions and activities, including the ability to learn, the ability to feel, express, and manage a range of positive and negative emotions, the ability to form and maintain good relationship with others, the ability to cope with and manage change and uncertainty, a positive view of the self, and he or she has specific goals in their lives. And then about Zomas. Who are this? Zomas, according to Pew Research, a Zomer is anyone born between 1997 and 2012. You can view in this image. The Zomas are also called as Generation Z. They are born between 1997 and 2012. Zomas is an informal term used to refer to the members of Generation Z. Zomas are also known as the Generation Z, I generation, Gen Z, and Generation Now. And then it is a timeline of generation in the Western world, as it is in Wikipedia article, with notable events by CMG Lee. And an impact of social media on Zomas. As compared to previous generations, Zomas are highly sophisticated. Zomas has high sophisticated media and computer environment, and they are more internet savvy and expert than their previous generation, which means Generation Y. They are also called as millennials. Generation Y also experienced technology, but unlike Zomas, unlike Generation Z, they are not digital natives and saw the development and advancement of technology across their childhood and early childhood. And then this generation is the safest. Generation Y or Generation Z or Zomas are the safest generation compared to previous generation through the increased through the increased interest in safety. Death rates from car accidents have decreased. However, they are more likely to die through suicide due to their emotional fragility. Zomas appears to be more scared of adult social interactions than physical injury. They would be the reasoning for an increase in depression and anxiety. Technology and mental health of Zomas. Technology is also a direct factor on the mental health of Zomas. Technology and social media provide a feeling of connectedness even when you are not really connected. This generation sees issues where parents don't feel like they spend time with their kids because they are glued on their phones, and groups of friends don't actually do anything together but look at social media. This feeling of independence that technology offers actually can lead to loneliness and depression for Zomas, because they are the first generation to have this much technology and social connection at their fingertips. One aspect of technology that is widely used by Zoomers is social media. Facebook, Snapchat, Instagram, WhatsApp, and Twitter have also gained in popularity and influence over them. And then Instagram was found to have the most negative overall effect on young people's mental health. The popular photo sharing app is the Instagram. It is negative. It has many negative impacts like body shaming, increases bullying, and leads to greater feelings of anxiety, depression, and loneliness. And then Zoomers are fragile in their mental health. I can justify it through these lines. Zoomers are fragile in their mental health because they experience social rejection more frequently than previous generations, because they have direct access to what their peers are doing. Monitoring their peers' upliftment on social media, most of the people are more likely to agree with the statement, "I'm frustrated, I'm lonely, and I wish to quit." Specifically, Facebook has many emotional consequences such as feelings of envy, feelings of lechery, feelings of wrath, feelings of sloth, feelings of gluttony, feelings of pride, and feelings of covetousness. In different perspective, or in my own perspective, I can say these feelings are the 7 deadliest sins which appeared in Dr. Faustus by Christopher Marlowe. It is one of the great play in English literature. Thus, I could say that Zoomers are stuck in the world of social media, like Dr. Faustus was stuck in between good versus bad, true versus elusive power. The good angels try to convince Faustus not to pursue unholy magic, but the evil angel encourages him to dwell into sorcery. Here, Facebook is in form of necromancy in the hands of Zoomers, which encourages them to dwell into sorcery. Because of social media, Zoomers cannot be stable in their mental process. Another way that social media can create a misperception of reality is through highlighting positive moments in life while excluding the difficult moments, and focusing more on the self by creating a positive and impossible social image. This creates an unrealistic expectations of reality, causing teens to think their lives are not as exciting as others, and causing teens to think that they are failures. A study showed that those that use Instagram have increased feelings on envy, because when using Instagram, we are watching other people's vacation photos, wedding announcements, and other positive life changes. Social media causes people to feel inadequate because they do not realize their friends fails at things too. Those who spend more time on their digital screens are more likely to be unhappy compared to those that have in-person contact. And then suggestions. There are few suggestions to recover from these fragilities. Seeking help from professional is one of the most important things to improve mental health. Other strategies that can help to reduce stress and loneliness and improve mental health are getting enough sleep, spending time with friends and family away from technology, physical activity that realizes positive chemicals into our body, and working to find ways to connect in real ways with people around us. And then a change of scene or a change of pace is good for your mental health too. And then as a concluding session, having solid mental health doesn't mean that you never go through bad times or experience emotional problems. We all go through disappointments, loss, and change. And while these are normal parts of life, they can still cause sadness, anxiety, and stress. But just as physically healthy people are better able to bounce back from illness or injury, people with strong mental health are better able to bounce back from adversity, trauma, and stress. And then thank you. Thank you, ma'am. Thank you for this opportunity. Thank you.
Thank you, Ramya. Thank you so much.
Thank you, ma'am.
Thank you, Ramya. Your presentation is very nice and a wonderful presentation. Participants, any queries from your side? Dear participants, Ramya, in your presentations in the suggestion slide, keeping away the family from the technology. Can you explain how can it be possible?
Sorry, ma'am. Can you repeat the question, ma'am?
Keep the family from the technology. One of your suggestions in your slide.
Spending time with friends and family away from technology. Yes, ma'am.
What are the ways to away from the technology? Is it possible in this digital world?
Not that much possible, but we can do it, ma'am, with our will and with our eagerness. We can do that because family relationship is nowadays it is brokening. We have to build up and we have to maintain the relationship with one another in our family. At least in our when we are in our home, we have to avoid the social media. At least inside the home, we have to avoid the social media.
Very good, Ramya. Participants, any queries regarding this paper? Shall we go to the next one? Next, I would like to invite Mrs. S. Jayamary, PhD scholar, Manoormem Sudana University. Please share your presentation.
Good afternoon, ma'am.
Good afternoon.
Please wait, ma'am. It's here is Jayamary from Manoormem Sudana University, Tirunelveli. So I'm going to present a paper on the importance of mental health to improve academic achievement of higher secondary students through problem-solving ability. Abstract. The main purpose: an universal relationship among mental health and academic achievement is a well-known phenomenon within the scientific literature, but how and when this affiliation develops is not absolutely understood, and there may be a lack of longitudinal population-based total research on young children. Early invention is crucial if institutions are to be found already during childhood. The aim of the present study was to investigate the development of the association between mental health and academic performance during the pandemic situation COVID-19.